Hello and welcome to the P&O podcast. This is episode 3. I'm delighted to be joined today by Alistair Beverley, who is the Physiotherapy Manager at Portland College. And we're going to be talking about people with learning disability and how our services could be better for this group of people. Alistair, do you want to give us a bit more background about you?
Yeah, so thank you, Matt. It's fantastic to be here, and fantastic to be here to talk to, engage with a different area of professionals. So far my Twitter tirades have been primarily directed at physiotherapists, with some linkage in with nurses. So to get involved with some podiatry and orthotists is fantastic as well. So I work at Portland College, as just mentioned, which is a college for people with physical and learning disabilities. And in the same way that you and I could go to college after we've done our GCSEs, we're a college that provides that same service, but specifically for people who have those physical or learning disabilities. And we have a wide spectrum, a wide range of people in terms of their capabilities. We've got people with autism, we have people with cerebral palsy, we've got people with Down syndrome, people who have global developmental delay, people with acquired brain injury at young ages. Some of them need physiotherapy support. We've also got occupational therapy support, speech and language therapy team. We also host a joint orthotics clinic with a local NHS services from Kingsmill Hospital. And they come to our college, and because we have a large proportion of people with physical disabilities who have a need for orthotics and podiatry support, they provide that to us on a regular basis. So, it's thankfully, I'm not coming into this blind in terms of knowing what you guys do and knowing how a good orthotist can work with people and change people with learning disabilities' lives. In terms of my background, I graduated in 2010 from Sheffield Hallam University. Was lucky enough to get a job then because they were like gold dust, working in the community for the NHS with people with learning disabilities for 2 years. Then I worked for a private healthcare organisation setting up a day centre or an MDT within a day centre for people with quite profound physical disabilities. Throughout that, I've also lucky enough to have 2 voluntary roles. So I am the physiotherapist for Team GB for Special Olympics Great Britain. So I'm very lucky to get to travel worldwide. Really, I've been to quite a few places with them now when they go to World Summer competitions. But I also have a side role as well, which is and this is a very long title, which I don't necessarily like, but it's the Clinical Director for Health and Wellbeing for Special Olympics Great Britain Fun Fitness. So that's a title which essentially means Special Olympics, the organisation, are trying to redress health inequalities, and doing that by providing free health screening at events that cover a range of specialities. So physiotherapy is one, podiatry is another one, audiology, optometry, dentistry, there's mental health, there's healthy lifestyles, and there's been a couple of others added recently. And the idea is that we provide health screening and then we signpost into mainstream services. And the idea of that role and ultimately the main role for me is to do myself out of a job so that people aren't needed to be specialists because people have their health met by mainstream services. Sorry, that's a slight diatribe, but yeah, I've got my finger in a number of different pies, and my set myself up as from a social media point of view as the LD physio, and just to try and give myself a platform to sort of spread the message.
Great. And so if we talk about some of the work that you do, if we perhaps, the aim of the podcast today is to look at how we can change our practices as orthotists or prosthetists as well, but predominantly orthotists, I think, are the group that see this population of patients most regularly. And if you think about your practice, working with patients with learning disabilities, perhaps at the college or anywhere else, and how you would approach practice with other patients that don't have learning disabilities, is it hugely different? Are there aspects that are the same? Are there certain things you focus on with one patient group more than others?
I think it's something that, particularly within physiotherapy, I don't necessarily approach things differently. And I think a lot of people will find that a bit odd and a bit jarring. They sort of think I'm going to come with this magic toolkit of lots of different bits of skills that you can learn from. And actually, it's about working with the individual that's in front of you and about being able to be flexible and responsive to the needs of that person. Now, I see people with and without learning disabilities, and my approach is the same. And it's about being good at building rapport with an individual. It's about knowing what's important to that person getting a little bit under the skin of who they are, and on a sort of surface level, but, you know, and finding some common ground and some common interests and building there and working forwards. Why is that important? Well, my job is to make people exercise, essentially, when it comes down to it, you know, make people exercise or engage in physical activity that has health benefits. They might be targeted in terms of back pain or rehabilitation. They might be just around general strength and conditioning work, or just about general fitness and activity levels. Exercise in its purest form is hard, painful, tiring. And actually, if somebody said to you, you never have to exercise again, you'd probably go, actually, that's probably quite a good, you're not going to have any physical or mental health issues. If you didn't exercise, you can sit on the sofa and watch Netflix and be like, spot on, that'd be perfect. Now, I have an underlying understanding, as many of us do, about the physical and mental health benefits of exercise, which is why I exercise, other than liking cake. But if you take away that underlying understanding of the benefits and why it's important to exercise, you just see that it's hard, tiring, and uncomfortable. And actually, within physio point of view, similarly with orthotics, we might be doing things that take people outside of their comfort zone, that might be a little bit uncomfortable, that might be a little bit painful. And so it comes back to the fact that you need to have that rapport and understand the individual so that you can know how far to push them, that they can trust you, that they can recognize that you have things that interest them. So what skills do I use? That do I approach it differently? Maybe from a legal standpoint, I have to. You know, there's things like reasonable adjustments that we have to do under the Equality Act. We have to look at capacity, which covers people with and without learning disabilities as well, but primarily used with people with learning disabilities. So from a legal standpoint, slightly differently. However, getting to know the individual is probably one of the most important skills that you can utilize, and finding some common ground. You know, one of the skills that I think that I have, I don't have any different physio skills. You know, I still do the same exercises and suggest similar exercises to any other physiotherapist. And in the same way with, you know, with orthotists as well, you know, you guys are going to be, you know, an AFO is an AFO. You're going to customize it to the person, but it ultimately, you know, you're looking at, you know, maintaining range of movement within the ankle, or, you know, supporting foot drop or whatever. But it's how you apply that and how you get that individual on side to be able to work with them so that they're going to want to engage with that. And I think, you know, going too hard too fast is one of the issues that a lot of people struggle with. You know, particularly when we've seen with our orthotic clinics that we host, that if we push for too much change too quickly, then that can be a big thing. And I think that's probably a big thing within mainstream services as well as learning disabilities. So yeah, do I treat people differently? Yes and no, double-edged sword. But ultimately, a lot of the core skills that we're taking on board as learning disability specialists are transferable skills that you can apply to anybody that you're going to work with them from here on in.
And I'd imagine that a large part of that is how well you communicate with patients. And that's, of course, important regardless of whether someone has a learning disability or not. And, you know, I think many people would just recognize that as good clinical practice, wouldn't they? Completely. And knowing where to pitch your communication levels for that individual. You know, people with learning disabilities, you know, definition of a learning disability is a difficulty undertaking, taking on new information that's given to them, and it affects all areas of their life. So it differs from learning difficulty, which would be an example of something like dyslexia or dyspraxia, that it affects one specific or one, you know, a few areas of your life. A learning disability is a deficit in or a difficulty taking on new information that affects all areas of your life. And so I've lost my train of thought now. See, I warned you that I sort of go off on these tangents. What was your question again there? Just about communication and you know, as you were saying, yeah, that's it makes sense. If you had a patient who you didn't know had a learning disability, or perhaps didn't at all, if they asked you to write something down for them, you would, of course, you'd do that, right? That's
exactly. And having those skills to recognize when somebody's not getting something that you're saying, because, you know, not everybody with a learning disability goes around with a big t-shirt on that says I've got a learning disability, or comes in with a carer, or comes in with a hospital passport. You know, a lot of people with learning disabilities out there have jobs. You know, sadly not enough of them are able to have jobs due to other inequalities. But you need to be able to recognize with any patient, you might have a patient that's not got a learning disability, that doesn't understand what you're talking about, but being able to recognize when someone's sat there going and then if you go, right, can you just tell me what you've understood from that? That's a completely different question. And that is a lot of the times when you get people with and without learning disabilities where they go, you know, I'm taking out of this, I don't know, from a physio point of view, that a massage will make it better. Well, actually, sorry to say that, but that's not what, but there's a whole thing in healthcare, and I'm sure you've read yourselves about it. People hear what they want to hear and take what they want to take from a consultation. So clarifying understanding is really, really important. And whether that means you need to provide, you have a legal duty of care to provide information that's at a level that a person can understand. So if you can have some symbols, signs, if you can change how you engage with that person, use simpler language, get better at using signs and Makaton, those are all skills that are not just going to benefit the people that you work with now, they're going to benefit all people. And they make you legally compliant. Unfortunately, there's a lot of laws out there that pertain to people with learning disabilities that don't seem to be enforced. But they're still laws, and you still are culpable if you just sit there and think I can just chat to people. If somebody's sat there going and comes out of your session and has got no idea what you've gone on with.
Yeah, and you mentioned about working with carers and and perhaps parents as well. If we're talking about younger patients, do you find that's of course it's something we have to do with children and pediatrics, but do you find working in in the sort of situations that you do that's more of a challenge, or it's more important perhaps for you?
I think it can be a challenge. I think it's something that a lot of healthcare professionals, even learning disability specialists, seem to struggle with. And currently within my Twitter social bubble, or whatever you want to call it, I've been trying to engage more with parents of people with learning disabilities to get their point of view, because I've only come at this from the point of view of a professional to an extent. My older brother's got Down syndrome, and so I've sort of seen the system a little bit from two sides. But I think that all too often parent voices are dismissed, and I think that can lead to a lot of frustration, and it can lead to fractured relationships. And ultimately, we need to sort of, to steal a phrase from Ellie Chapel, flip the narrative around parents, and just rather than seeing parents as troublemakers, seeing parents who want the best for their son or daughter and have had to fight tooth and nail to get every single day of care, support, money, whatever. The system is there that means that the people who shout the loudest get the most, and it shouldn't be like that, but it is like that. But it means that people shouting and coming at it from legal standpoints becomes a default position. And actually, if you can get under the skin and go, look, I'm here to help and I want to help, and how can I understand your point of view a lot better, those parents are going to have a wealth of information, a wealth of knowledge. There's nobody who knows somebody better than parents. And if you can have that positive working relationship with parents or carers, then that's going to help you all the more, because ultimately your consultation or time with that person is limited. If you see them even under reasonable adjustments, if you give them an hour appointment, there's 23 hours in the rest of the day where they're not with you. And if they don't see the value in your splint or your device or your prosthesis that you've given somebody, then they're not going to buy into it as well. If that person is there and can't make the decision for themselves, and their carers are sat there going, well, this is rubbish, or he's never going to tolerate that, and you don't engage them or listen with them, then ultimately you're setting yourself up to fail from the start.
And so when it comes to working with patients or with carers, regardless of who it is there anything you think that people can do in a mainstream clinic? Is there anything they can focus on changing, or just try and do a little bit more in order just to facilitate these kind of meetings better? Because if you look around the statistics for people with learning disabilities, that they typically just don't access these services, and that's either because they can't or they choose not to, and for whatever reason. Are there things that we can reasonably change in day-to-day practice that will help to encourage these people to come?
I think improving awareness and understanding around the practice, and I think ultimately a lot of it comes down to giving people more time, which is there enshrined in law under the Equality Act of under reasonable adjustments. And if we have systems that are better built or shaped so that people can signpost that this person may have a learning disability, may need more time, if that's sort of built into a system at the point of appointment making, so if you own a private clinic or practice for whatever, and if your first contact with that person has an ability for somebody to signpost that this person has a learning disability, then that can change the whole pathway. You can suggest, right, well, that's great, do you need help and support, do you feel you need extra time, do you want to bring in your hospital passport? Now, hospital passports, if you don't know are a document which are, some places call them grab sheets, and they are a document which has got essentially all the information you'd want from a subjective assessment if somebody is picked up in an ambulance. But there's a lot of information that we can take on there from a clinic point of view, such as, you know, name, address, date of birth, medications, but also I say softer things, they're not softer things that are important to the individual, how that person communicates, what they like, what they don't like. They might not like mushy peas. They might not like loud noises. They might not like the colour blue. So it's not necessarily that there is one thing other than trying to understand the individual that you're working with. But if we can look at how we build our systems, which is not a small thing, then it can make a much better pathway or a much better journey for that individual, because you can just take a sidestep from the main pathway and follow a pathway, but just make it so that it's adjusted for that person's needs. And as I say, you know, not everybody with a learning disability is going to need all these things.
Yeah.
It's only a proportion that will. So is it people sort of panic? Well, it's going to take up all my time, and I'm going to have to devote half a day to this. Well, it might not be. It might be that you say, look, this person's got an appointment next week. They're quite nervous. Well, you say, right, well, we've got a lunch half hour. If they wanted to come in while it's quiet, they can come and see where we're going to meet. They can come and have a look around. We're going to be eating our lunch. I'll come and say hello for 10 minutes. We'll not overwhelm them. And then they know where they're coming. We can take some photographs and they can build a social story around it. We can work with the speech and language therapy team so that when that next person comes in next time, they know where they are. Things haven't changed. They know where they're going. They know who they're going to meet. You know, just lots of little things that make a big difference to the individual. And, you know, ultimately we need compliance with services, and I have, you know, a bit of a bee in my bonnet about the Mental Capacity Act in terms of its workability to the letter of the law. But whether or not somebody understands or has capacity to make a decision for themselves, if that person doesn't want to do the thing that you want them to do, it does not matter whether or not they understand it or have capacity. You know, we're not surgeons. We can't, you know, not that we would, put people to sleep to be able to do procedures on them. It's not surgery. We need compliance. You need compliance that somebody needs to wear something. I need compliance that ultimately people need to wear what you provide, and that people need to do exercises. But we can't force that on people. So they're small things that will make a big difference to the overall outcome that you're working with.
And they're the sorts of things, again, that you would consider important with any patient. You know, if you don't want them to associate a negative experience with a device that they take home with them, for example, and they're all the sorts of things that, you know, you would try and do in regular practice, you know, with the general population. In terms of things like consistency. So, for example, often with orthotists, you will have an orthotist and you'll see the same one. But in terms of things like clinic rooms and spaces being consistent over time, is that an important consideration or not really?
It depends very, again, it's a massive caveat of all my answers. It makes it quite simple, to be honest, because you just say it depends on the individual. Sure. But it really does, you know, people with learning disabilities are as varied as the general population. Indeed, they are part of the general population, and that's the sort of distinction we're trying to make with this, is make it included, not specialism. But I think, again, if you've got a system that is in place that enables somebody to flag up these things. So if you've got somebody who likes consistency, you know, I'd like to be seen by the same therapist, then you can plan in, if you know that you are on annual leave the week after next, you can see them next week, but then it's going to be somebody else. We might go, well, let's maybe not give it to Matt if they need consistency. If they're going to need to see two people, well, maybe under reasonable adjustments, we say, and there's no other way around it, we'll say, right, let's come and say hello and you can both be in on that first appointment. If they do like the same place, then you can just make sure that you pencil in the diary that that person's going to be seen in that same clinic. But if you know what the needs may be or needs of people with learning disabilities may be, then you can give people pathways that they can signpost that to you, which will make the whole process a lot easier.
And interestingly, it seems to me from speaking to you here and previously as well, that all of these things seem like they have the potential to just improve clinical practice for every patient. If you have the ability to signpost something that improves your experience, then
completely. That's a real bugbear that I see. You know, I think there is a big medical unspoken hierarchy of which learning disabilities is at the bottom of, unfortunately, and I think part of that's down to history, and I think part of that's down to that we as a speciality aren't very good at. We have a PR problem, I think, is probably the best way of putting it. But there's a lot that can be learned, and I say this to everybody that I work with or speak to or get the chance to speak to. And I was lucky enough to get some time with Sheffield Hallam University undergrads, and I said, the skills that I'm going to talk to you today will benefit every single contact that you have for the rest of your professional career. They're not just skills that you'll employ with people with learning disabilities. They are skills that will keep you legally compliant, but would also enhance the experience for every patient that you see, which is why we have a practice where we can see people with and without learning disabilities. You know, I mean, how many places who don't see people with learning disabilities could open up a case of 30 people with learning disabilities like that? We can, because the skills are equally applicable, and the feedback from the people that we see who haven't got learning disabilities is just as positive as the people who have, thankfully.
And do you think this is not, so from my experience of working in schools, which is admittedly different, but, you know, I've worked with children that have learning disabilities, and I know that there are various issues around, you know, anything being inclusive, which really shouldn't be issues, I think, if I'm being honest. They seem, but perhaps that's a discussion for another day. But do you think that there's this sort of a stigma attached to patients with learning disabilities?
Yeah, I certainly do, and I think that there is something, for want of a better phrase, something wrong with the healthcare system as a whole. You know, if we take, for example, as it's a hot topic and rightfully is being addressed, it's been addressed by Matt Hancock's finally sat up and listened, that during the start of the pandemic, there were unlawful DNA CPR, so do not attempt cardiopulmonary resuscitation orders, placed on people with learning disabilities. Now, they should be placed on people whose discussions should be had around those with people who've got medical issues. But if listeners take one thing away from this podcast, it's to remember that a learning disability is not a medical healthcare condition. It is a difficulty taking on new information that affects all areas of your life. There's nothing medical about it. Yes, people with learning disabilities have a higher proportion of comorbidities, but, you know, just not being able to take on new information is associated with, on average, a 17-year reduced life expectancy. You know, and that doesn't even take into account comorbidities. If you look into comorbidities, the life expectancy is drastically reduced. And I think there is something broken within the healthcare system around our values. And I say our, you know, I'm part of that healthcare system. And that we can say that because somebody can't take on new information, we don't value their life, and therefore their life is not worth saving in the event of a cardiac arrest or whatever. You know, last year, if anybody who's interested a little bit further in this, there's a it's a very important piece of work that started with Bristol University called the LEADER Project, which is investigations into deaths of people with learning disability. Now, the idea is that they would set up no-fault investigations that are not necessarily legal, but look at what could we learn from the death of this person, what could we change systemically that would help or maybe avoided this. And, you know, there were 19 cases in 2018 where Down syndrome was given as a reason for a DNA CPR, which, you know, is the sole reason as well. I'm not saying they've got Down syndrome and cardiac issues and breathing problems and atlantoaxial instability, just that they got Down syndrome. And so yeah, I have a real beef with how healthcare as a whole provides services to people with learning disabilities, and I think there are definite changes that could be made.
And from that report as well, so I had a look at that a few days ago as well, and there were also, it was quite shocking to me to find that a large proportion of those deaths were found to be because of people not responding to information they've been given, or perhaps not understanding, and you think those are things that in that's basic clinical practice, isn't it, to communicate with your patients regardless of what that means?
Completely, you are completely right. And, you know, everybody with learning disability, you might not know this, is entitled to an annual health check from their GP, so they can go and get what I like to call an MOT from your GP. Every year, GPs are funded to provide this, and last year I think the uptake was less than half of people who were eligible for that service. It's improved, because years before that, in 2010, was about 4%. It's when it was first rolled out, but it's still only about half. And when there was some research done into why this happened, and a lot of it was around people didn't know. people didn't know. And I'm like, these are people who are engaged in healthcare services, and healthcare practitioners either aren't aware or aren't signposting in a way that people can engage with. It's not that the services aren't there, that they are, but again, it comes down to how we communicate that.
Mm-hmm.
So yeah.
In terms of working in, so we were talking here a lot kind of about general clinical practice. In terms of specifically orthotic practice, it's also interesting to note that a lot of patients that have learning disabilities also have, as you say, other conditions, whether they're related to that learning disability or not.
Mm-hmm.
But they can actually also be really, really badly affected by reductions in mobility. So whether that's completely unable to mobilize, or whether that's just a reduction in the quality of some of their movements. And so it seems quite interesting that to hear that a lot of those patients are not engaging with services, but actually from an orthotist point of view, they seem like a key group of patients that we would expect to see quite a lot.
Certainly, and just to touch on those figures, and definitely the importance of the work that you guys are doing with people with learning disabilities and trying to keep people mobile, and that's where that's why we naturally already work with an orthotic team due to the overlapping, trying to keep people on their feet. And I know there's some people who sort of say, well, somebody's going off their feet or falling, there are risks inherent in that. I understand that, but if you are unable to get out of your chair yourself during the day, that is associated with, I think it's 7 times risk of premature death. So it's 7-fold increase in the risk of premature death relative to people with learning disabilities who are fully mobile.
Mm-hmm.
If you are partially mobile, so if you can get up and do a step round transfer, so if you can get out of your chair, shuffle around, sit on a sofa, but you can't stand or exercise or mobilize for a long period of time, or need support to do that, then the risk of death still doubles relative to people with learning disabilities who are fully mobile. Now, we already touched on the fact that people with learning disabilities have lower life expectancy already. Mm. And then if you can then double the chance of premature death risk for people who are partially mobile, and then I don't know what the thingy for 7 would be, but 7 times on top of that as well, you start to see that the life expectancy for a lot of people with learning disabilities is not good, and that doesn't necessarily come down to the complexity of the person. That comes down to poor healthcare.
Mm. And this is also then potentially a group of people that we as physiotherapists or occupational therapists or orthotists can have a genuinely huge impact with the work that we do. Of course, there's no guarantee that you're ever going to be successful, but they really do seem to be a key group of patients where us as professionals can make a massive difference.
I certainly think so, and there's a lot of reactive work going on around people with learning disabilities at the moment. How to support people better in hospital. But another one of my soapboxes is, why don't we try and keep people healthy and stop them going into hospital in the first place? So if we keep people on their feet, they're going to be stimulating their cardiovascular systems. They're going to be improving health. They're likely to have lower body mass and all the issues that are associated with increased body mass and bone density and diabetes and risk of cancer and heart disease or cardiovascular issues. All those sorts of things can be managed if services that are there can be supported to provide preventative healthcare, and keeping people on their feet or allowing people to engage in exercise is massively important. If I went to see my GP and I said, "Hello GP, I'm going to sit on my sofa for the next 18 months," a GP would probably say that's not the best thing for your health. But for somebody with a learning disability, we give them a wheelchair and say, right, off you go, with no support to stay on your feet, with no addressing of potential foot pain or knee pain or hip pain or back pain. We'd crack on it. If you want some, here, have some painkillers. In fact, we'll give you prophylactic painkillers. But actually, there's no support there to keep people from getting into those situations where they need to keep medical care in the first place.
So to try and kind of summarize this a little bit, because I realize here we've talked about a lot of big issues, which has been really good. It's really important. And I know from talking to and seeing other things that you've done that's, it is important. And I know it's important to you personally. But I think, as professionals, we've got a collective responsibility for any other patient group. If there was any patient group where we knew they weren't accessing services that they needed, or they weren't receiving good quality care. We, as professionals, we need to do something about that, and that's exactly the same here. And so from the things we've spoken about, it seems that actually practice in clinics itself, or our behavior as clinicians is not necessarily needing to be changed. It's still exactly the same things that we would focus on with any other patient. It's about good communication, or appropriate communication. Yeah. And it's about building trust and rapport, which is key in any patient group, but perhaps is maybe even more of a big deal here. And that they're things that would help to improve healthcare for anybody that accesses it.
Mm-hmm. Yeah, no, certainly vitally important. Just one other thing just to touch on in terms of seeing people in clinic and about things that people with learning disabilities may present with. I just want to touch on sensory processing. So sensory processing is how our brain deals with sensory information that's given to us from our senses, so sight, taste, touch, smell, hearing. Now, there's some evidence out there to say that people specifically with autism, but again, it can be true of anybody with a learning disability, that they have a brain that is wired slightly differently, or a brain that is able to process sensory information slightly differently. And that can mean that the brain becomes overwhelmed because the brain doesn't necessarily know what's important. So right now we're sat here, we're sat on chairs, we've got clothes on, thankfully, just for anybody on the podcast. I've got a fan in the background, the birds are singing outside. My brain can filter all that information out because it goes, you don't need to know that right now. Once you've put a watch on or something in the morning, the brain doesn't tell you all day, you've got a watch on, you've got a watch on, you've got a watch on, because you just become overloaded. And actually, we do see similar sorts of things in terms of in people without sensory processing challenges. When you're tired, when you're stressed, if the classic thing that I see is what we can find is that when we're trying to find an address in a car, we turn the radio down to look for the address. And we sort of laugh at that, how does not listening to the radio help us see better? But actually it diverts brain power when we really need to focus. For some people with learning disabilities, it's like trying to find the address with the radio turned up full and you've got car headlights in your face. So again, looking at signposting to your practice and creating that positive pathway, understanding that somebody may not like bright lights, bright colours, or equally they might do, or they might not like it if you, I don't know, speak very loudly. You might have to speak quite quietly. Equally, they might be undersensitive to these things. So you can see some people who tend to flap because they lack, they may lack proprioceptive feedback in the brain. Generally, you can have people who shake hands very, very hard or hug quite hard, who like weighted jackets or weighted vests, or like tight clothing. Again, that can be due to an underrepresentation of proprioceptive feedback in the muscles. But from a sensory point of view, if there's a busy clinic environment and, if you hear somebody starts to rock or make noise, as long as that's not causing issue to them or their safety, then you can carry on normally, because most people are just trying to manage what's going on. And for some people, if they create internal noise, it drowns out external noise. But for other people, that might just be how they focus and how they fluctuate, and just allow people to do what we call stimming. If you want to read up on stimming, it's something that's quite out there within the literature, and actually really, really interesting. We all stim, actually, whether it's a pen clicker or a nail biter or a hair twiddler, we all do it. It's just a comfort thing. So yeah, just bear in mind those things as well when you're working with people. Sorry to diverge again.
No, that's great. And you mentioned people with autism. It's quite sort of widely, I don't want to say known, because it's not necessarily always true for someone that has autism, but it's quite widely recognized that, particularly people with autism, sometimes, like a loud waiting room or busy places can be, quite uncomfortable. And that can have a large bearing on an appointment going forward. If you have someone coming into an appointment that's already agitated, just like with any other patient, if there's something you can do to remove that source of agitation, it's worth thinking about.
You certainly should do that, and then just to caveat that, they're actually not everybody with autism has a learning disability, and I think that's a lot. Autistic people can get quite rightly, annoyed by that. I think the General Medical Council, I believe, or somebody I think it's the GMC, has come out. Sorry, it's a ridiculous thing to have to say, isn't it? But she's come out that she's autistic, and autistic people are in at every level of society, and they function. I use the word function again. I don't want to sound like I'm upsetting people as a neurotypical myself. that, you know, people with autism can live completely normal lives and have jobs and succeed, but there are people with autism who have learning disabilities, but it's not everybody with autism has a learning disability.
Sure, and that point about you know, you could have, you know, you could be not neurotypical for whatever reason, or you could have any learning disability that, you know, we could list, but that doesn't necessarily tell you anything about a patient, does it? It doesn't tell you anything about them before you've actually assessed them. Or
No, exactly. I mean, it can from a medical point of view, it can flag up some things that you might want to check out. So I don't know, for example, people with, touched it before, Down syndrome can have higher incidence of cardiac issues quite commonly. There's some thyroid issues as well, generally underactive, but can be overactive as well. And that can lead to issues with weight management. Similarly, renal issues and also intellectual instability are prevalent, but in terms of those are the medical side of things, but you still would treat the individual in the same way that somebody with cerebral palsy, you would work with the person with cerebral palsy. Yes, you may think, well, they might have mobility issues, they may have tonal issues, they may need support around their nighttime position and sleep systems, or maybe thoracic jackets or splints. But what you would do is that would guide your sort of thinking in your head, but you'd work with, for example, Ryan, who has hopes and dreams and aspirations and who wants to be the first disabled actor on Broadway in a power chair, you know, who wants to go out and do and live his life. And he's not his disability, and you shouldn't treat anybody as such. Some other points, particularly another one is that's quite commonly people attach stigma to is autism. People live full, happy lives, have jobs, have children, have families, get married, you know, every single other thing that you would do. But they are autistic, but that is not who they are. That's part of them, but it's not the entirety of them. But so if you saw somebody who had autism on the medical information or past medical history, then you would be aware of that, but you wouldn't alter or divert from working on what is important to that person and all the stuff we touched on earlier on. And I think there's a lot of stigma associated to labels within learning disabilities. And I think one lady that has really taken what is a horrific situation, thinking of autism, is Paula McGowan. Tragically, she lost her son Oliver from a hospital admission where he was potentially mismanaged, and that led to his premature death in his late teens. Paula has campaigned tirelessly and has actually won some significant battles, in so much as she has got what's called the Oliver McGowan mandatory training. So that means all NHS and social care staff are going to have mandatory training around autism and learning disabilities, and I think that is of vital importance, and hopefully will help people to understand more of the needs, you know. And this whole sort of podcast and the whole work that we've been doing is around trying to highlight the needs of this group. It's not about necessarily saying that they are any different to anybody else. There are specifics that are different, yes, but those specifics and how you adapt to them will benefit everybody. And that's something I keep coming back to in everything that I say and do, and touched on it a few times already. It's just if you learn to make adjustments or engage people with people with learning disabilities, then you can benefit everybody in the same way that if you build a building that just has ramps and lifts, everybody can use them. Whereas if you build a building that just has stairs, you exclude a proportion of society.
Mm. And so related to that, then, are there, you know, it sounds, obviously it's a horrific situation for anybody to be in, and it sounds like a very, you know, it's a very sad and tragic thing, but there is some positive coming from that. Along that line of thinking, are there any other sources of training or education that you would recommend to someone who works clinically and wants to know more about this sort of thing?
Yeah, I mean, firstly, there's Learning Disability England, who are a great source of information, guidance and support. They help with advocacy on behalf of people with learning disabilities. They help people with learning disabilities to self-advocate, and also can provide wider information out there to healthcare professionals. We touched earlier on about sensory processing, and there's one lady whose name always comes up for me is a lady called Joanna Grace. She runs the sensory projects, and has done a TEDx talk on, as well as other talks, on sensory processing, on how we value people, and that not necessarily what you expect as a positive outcome for one person is necessarily what you'd expect for somebody else. She focuses primarily on people with profound and multiple learning disabilities, and is a great speaker as well. She's autistic herself, but is just compassionate, knowledgeable, humorous. She's great. We touched earlier on postural management and about, very briefly, on spinal jackets and people with cerebral palsy. If you'd like to know anything more about that, then I would recommend you follow a lady called Sarah Clayton, who's sort of a lady who invented, or sort of was one of the pioneers in the postural management side of things. If you are looking for some support around communication, then there is the Royal College of Speech Therapists, who have their 5 good communication standards, but also your local community learning disability team. We're talking on some big picture things in this podcast, and a lot of what I'm doing is trying to target the big picture. So shout out to Anne Gates, who is Exercise Works, who is also really worth a follow if you're interested in exercise. She was the one who was sort of teaching me to go from saying, well, aren't physios blah blah blah, physio, and she was like, well, your issue is bigger than this. So we're talking about some big things, but on a ground, so say on a face-to-face level, if you're looking for support to engage with Sarah or Daniel, who's coming in next week and has a learning disability, then get in touch with the community learning disability team. They will be happy to help. They are incredibly stretched, but there is a list of them on the NHS website. If you just Google community learning disability team, there's physios, speech therapists, occupational therapists, nurses, social workers, and they have access to a multitude of professionals and other professions and specialities, and they can help you on that person-to-person level. Practical support for the individual that you're going to be seeing next, or support for yourself on a clinic level, and maybe some suggestions about what the differences that you can make in your clinic that will help benefit people with learning disabilities.
That sounds great. And just to be really clear, when we talk about communication here all the way through, we are talking about good communication, which might include simplifying certain things, but it's not necessarily simplifying communication. It's about appropriate and relevant communication for whichever individual we're speaking to.
Yeah, no, it certainly is. And communication, as was mentioned before, isn't just around spoken word, and it's not even just around spoken word and tone of voice. It's around how you portray yourself. It's around your body language. It's around, people may use signs, they might use symbols, they might use photographs. People can use things called PECS cards, where they use signs and symbols to understand what's going on. People can have visual timetables where they have symbols or photos of what's going to be happening during the day, and that can be really good preparation for people coming into your clinic. So if you can get some photos of your clinic that you can send out to people with learning disabilities, because you know that they're coming, because you've got a good pathway into your service that people can signpost they've got additional needs, then that can help people. Communication is everything that we do, unfortunately, and I think it's a skill that's really undervalued. At undergraduate level, I wasn't necessarily taught much about communication, and yet other areas of physiotherapy, and I think other areas of healthcare, are recognizing that your relationship and your rapport and how you communicate with patients has almost as big a bearing, if not some would say a bigger bearing, on positive clinical outcome than the actual treatment that you do. If people are happy with what you do and they like you and they understand what you're doing and you have that good rapport, that can be as important to a clinical outcome as I gave you squats, or I gave you an AFA, or I gave you an insole, or a wrist splint or something.
And all of the things that we've spoken about in terms of what difference you could make kind of on a ground level, face-to-face level, like you said, that's all really facilitated by giving people as you say, the chance to signpost things. Because if you don't know who's coming into your clinic and you don't know what their I mean, I use the word needs, but I suppose it's also preferences, isn't it? For anybody, it's not just specific to people that have learning disabilities. If you're not aware of what they need or what to avoid, then you can't possibly make arrangements for that. So we talk about hospital passports and you mentioned earlier about having a chance to meet people, or at least see people, or see pictures of where people might be going. All of those things are only made possible if you know about them beforehand. And so giving people the opportunity to signpost anything really is key.
Yeah, certainly. In the same way that you can have for a chaperone, I think it's important that you be able to ask for a low visual stimuli environment, or a low quiet space because somebody's got an auditory processing sensitivity.
In terms of people watching, if you are interested, and I hope you are, in things that we've spoken about today, and kind of the wider issues, I'd recommend following Alistair on Twitter. He's at the LD Physio, and I know you're constantly trying to encourage debate more than anything else, and raising issues, and just encouraging people to think about things they might not otherwise.
Yeah, I think so. And as I mentioned before, I'm no different to any other physiotherapists. I just have skills that I apply in a slightly different way. My exercises are the same, and it's about trying to improve understanding of that amongst healthcare professionals more widely. And as you said, recently we've started something called Tough Topics in LD, which is about trying to get LD practitioners and professionals, specific professionals, to look at some of the topics that we don't necessarily, we might sweep under the carpet. So I'm about trying to start a conversation, I think is the best way of putting it. As you mentioned, I'm on Twitter, I'm on Instagram, at _the LD physio _, not quite sure why I needed to put that in, but don't have a great following on Instagram because I don't get in a flesh out, I understand. And I'm also on LinkedIn as myself, Alistair Beverley, as well.
Okay, great. And Alistair, thank you so much for taking the time today. It's certainly been very useful and interesting for me, and I hope other people watching too. And I think just to kind of summarize that, in terms of what we can do as clinicians for people with learning disabilities, is really not that different from what we would expect to do for any other patient. Is that right?
Yeah, no, exactly. And as I've hammered home the point is, 2 points is that learning disability is not a medical healthcare condition, so don't treat it as such. And if you improve your skills and can tailor your skills to working with people with learning disabilities and improve those skills, then you will benefit every single clinical contact you will make from now on. If you learn about trying to build rapport, understand the individual, understand how to engage that individual on a positive level, particularly within our professions where we can't put people to sleep and do surgery on them because they lack capacity, or whatever, we need that buy-in from the individual. Then it's going to benefit every single person that you see.
Excellent. Thanks a lot again, Alistair. It's been really great talking to you. Cheers.
Thank you very much.